The wake of the Titanic was perfect until it was too late to do anything about it. All the dials were perfect, but they didn't look forward. They didn't have binoculars. That was one of the problems that they faced. They didn't have binoculars to save money. So I'm going to look forward and look at the future, not because I have visions. Visions get you a psychiatric referral or sainthood, because, in the words of William Gibson, the science fiction writer, the future is here, it's just not evenly distributed. So everything I'm going to tell you, I can see happening somewhere. And it's a very important issue about the future is not like the Isle of Wight or Mount Everest waiting for our arrival. The future is much more like the Great Western Railway. Something we imagine, plan and build. Something you will imagine, plan and build. And if you don't do it, other people will. Now I think it's very important, the concept of building the future, and it's very important that it's you that do it, because you're going to manage the future. I have always wondered why it is we don't get more young people involved in running the health service, and I read a little book called Operation Snakebite, and it's about a little battle in Afghanistan, and at the end of that I was very clear why young people make decisions in the army. The reason is that old people can't run fast enough. So the old people aren't on the front line, whereas in the health service, the old people are still in the front line. So we're planning ways in which we get selectively people like yourselves involved in changing the way things work. So you have to be confident that you're the ones who are going to build the service. But it is helpful to look back a little bit, and we have had two revolutions in healthcare. The first revolution was the public health revolution, and the picture here is the famous map of Seoul, John Snow's map. Now, the first industrial revolution and the first healthcare revolution was based on empiricism, common sense. John Snow worked out it was the water, not the air, that caused cholera. The second healthcare revolution, whose major achievements are listed in the right-hand side, was driven by science, and it's been fantastic. My 40 years in medicine have been astonishing. That because of the health service, people are living longer with fewer years of disability. But at the end of 40 years of progress, every society in the world faces these problems. Problems of inequity, failure to prevent disease, failure to get research into practice, waste of resources, harm for patients, even when quality is high, and huge variation. And we published atlases showing the variation from some operations or treatments, maybe fourfold or 50-fold. Everyone thinking they're doing a good job. Now you see this in tax-based health services, insurance-based health services, private health services. Structure doesn't matter. I've had 20 reorganizations of the health service. Most of them have made no difference at all. This one is a bit more important because it's got the clinicians at the center of it, as I'll speak about. So, what are we going to do about this? We can't deal with this, but we have to tackle this because coming up is an iceberg. And here's what the iceberg looks like. Need and demand will rise. Money will be constant, may go up, but it won't keep up with need and demand. And another factor here that will be in the next 20 years of much more important than money will be carbon. The carbon footprint of the health service is to come down dramatically. And most of the carbon footprint is due not to heating and lighting, but to staff and patient travel and the carbon in drugs and equipment. Climate change is the biggest threat to health in the 21st century, and the health service is a major producer of carbon. So these are the things that you're going to have to manage. And this is work of Manuel Castel, who's a historian, and he talks about the third industrial revolution. And the third industrial revolution is driven by three forces: citizens, knowledge, and this, the smartphone. When dealing with an older audience, I always ask, how many of you don't have smartphones? And a number of them put their hand up. It's quite a smug thing to do in the middle class, not have a smartphone. And I say to them three things. Firstly, poor people have smartphones. Secondly, poor people have know how to use their smartphone. It's a very important thing for them. I work as a volunteer with the London Homeless Programme, and half of homeless people have got a smartphone or they're on the web. And thirdly, the third factor is that this will be the way in which things happen. Someone your age said to me at a meeting last month, when will the NHS get a message, my generation doesn't do envelopes? We need to think in a new way of doing things. And this is the revolution, particularly at the moment, obvious in Africa and India, but in England too. So the revolution is underway. Now, what I'd like to do is get you to think a little bit about this yourself. So what I've done here is summarise the way we used to do things in the 20th century. This is 20th century healthcare, and you can see a number of features of it. But what we've inherited from the 20th century is a square peg for the round hole. The world is completely different, and the health service has to be completely different. So what I'd like to do is just to turn to your neighbour for a couple of minutes. You introduce yourself if you don't know another, and think, what have I put down as a result of, I think it's now 43 meetings like this. What are the key features of 21st century healthcare? So I'd like to come up with at least 2, all right? So, for example, clinician-centred care will become patient-centred care. The clinician was the most important person in the 20th century. The patient is the most important person in the 21st century. Okay, 2 minutes to design healthcare in the 21st century, starting now. The evidence is you'll remember more what you said to your neighbour than what I've said to you. That's education evidence. So it's a very powerful technique, the amount of brain power. Let's just take 1 or 2 bits of feedback. Would people like to volunteer? Don't worry if you don't want to, I just point, it's much simpler that way. Would people like to volunteer just one thing? Yes, shout out.
Primary care focus.
Yeah, primary care focus, I'll come back to that, yeah, good. Lady in red?
It's patient-centered holistic approach.
Yeah, patient-centered holistic, yes. Lady in blue,
I would say that better electronic systems
Yes.
for transferring patient notes between hospitals and GP surgeries.
yes. Someone said to me last year, why is it my hairdresser, a woman said, why is it my hairdresser can send me information on my phone but not the NHS? The answer? Hairdressers had 5 years of education and a 6-year postgraduate training, that's obviously the reason. Yeah. Second row here.
More of a focus on preventative care.
Preventive care, yep. Okay, 1 each from the panel.
Good care for unknown patients.
Good care for unknown patients, Ian.
Joined up IT.
Joined up IT.
And much more self-care by patients.
I can, this is now, I think, the 43rd time I've done this, and it is getting fairly consistent. You see things like take care for populations. This is the issue here. Everything we look at is that some people from certain areas don't get as much healthcare as others. So we're looking at the way in which specialists will be thinking about populations, the patients we don't see. Focus on systems driven by knowledge. Well, that has to require this thing called the internet. You know, the health service may come into the 21st century at some stage in the way it uses these things. So here's the sorts of issues that are changing. We may come back to this, and what I'd like to do actually is to write down the whole of the lead in and get your views on it. Get this. This is what we call design, how we design something new. Let me just cover 1 or 2 of these areas, and the first one is to do with value. Now, there is always a dominant paradigm in any organisation, the dominant paradigm in the NHS. So from 1948, what was the most important thing about healthcare? Healthcare was freedom. Then, in 1971, a man called Archie Cochrane published a book called Effectiveness and Efficiency. And this led on to things like the Cochrane collaboration, but we entered the effectiveness paradigm, which became the evidence-based paradigm. Then in the 1990s, we started worrying about cost effectiveness. So it wasn't just effectiveness, it was cost. And in the last 10 years, we've been focused on quality and safety. But we're now moving on to a new paradigm. And that paradigm is value. Value. Now, it doesn't mean that quality and safety are unimportant. They are still very important. But value is the relationship of outcomes to costs. So we have to think about the resources that we use as well as the outcomes. Now here's the sorts of issues that you will be involved in. So the first thing is how we divide the cake. And here, gastrointestinal 4 billion, respiratory 5 billion, cancer 7 billion. This is the national expenditure on different types of condition. And let's just, how much do we spend in mental health? I'm going to ask you to vote. I'm going to give you 3 options. 1 to 4 billion, 4 to 8 billion, and over 8 billion, okay? So that's 4, 5, 7, and I'm now going to ask you for mental health. How many think mental health is 1 to 4 billion? 4 to 8 billion? Over 8? Yeah, it's 11 billion. 11 billion. Not counting the fact that within respiratory and gastrointestinal and neurology, there's probably another 5 billion that's tied up in problems that are primarily psychological or psychosocial. Now, we then start to allocate resources to specific conditions. Now, lots of people have more than one condition, of course, and the way I sometimes think about this is say, well, there's something called complexity. Complexity is an 80-year-old woman with 4 diagnoses, 7 prescriptions, looked after by a 50-year-old daughter with an alcoholic husband and an unemployed son at home. Standard general practice. Are any of you going to be general practitioners? That's standard. General practitioners are great at complexity. But of those 4 conditions, one of them becomes complicated, and then you refer to a specialist service. So, complexity and complicated. Now, in the past, you see, supposing we want to develop sleep apnea services, people bid for more resources. But there are no more resources. So, the next move is to say to respiratory physicians, which some of you will become, you have to make decisions about the priorities. You've heard of clinical commissioning groups and primary care trusts. There's no way they've got the intellectual firepower to decide should they shift money from sleep apnea to asthma to COPD. It's usually not money, of course, it's beds and physiotherapists and the like. A friend phoned me up from Bradford and said they wanted more money for sleep apnea in Bradford, the respiratory people. What should I do? I said, I'll tell you what to do. You've got the asthma boys and girls and the COPD boys and girls and the sleep apnea boys and girls in the room and lock the door. They will have to make a decision what to do. Even within bronchitis, it's a very interesting study being done by respiratory physicians and general practitioners with a special interest, and they've come to the conclusion that what they need to do is to shift money out of drug therapy to rehabilitation and smoking cessation. So they're starting to, these will be decisions that people like you will make. The word I find an interesting word is the word stewardship. A stewardship, it comes from the environmental field, but the good steward leaves the land in better condition than they find it. The older people, us, what are we handing on to you? What are we giving you to manage? Still many problems that should have been tackled, which you will have to tackle. We've not been as good stewards of the resource. But increasingly you will be expected to be the stewards of the resource. Now, the second issue I'd like to speak about is integrated systems. And I like to think of the healthcare archipelago, and that's what it looks like. So general practice, that's £7 billion, mental health, £11 billion, hospitals, £60 billion, community services, about £10 billion. That's what it's been like since 1948, with the occasional ferry boat going between these islands. And all the money flows down these channels. And this is the same in almost every country, because these reflect long-standing things about the way we train people like yourselves. And the chap at the back who mentioned primary care, about this stage, if I'm speaking and working with people in Somerset or Kent or Huddersfield, I say, well, let's start talking systems. And I'm going to ban a number of words. I'm going to ban primary and secondary, acute and community, outpatients, banned. These are 20th century words, 19th century words. We need to talk about systems. And this is what a system looks like here. A system is a set of activities with a common set of objectives. So take something like epilepsy, or headache, or inflammatory bowel disease. Then self-care is the most common type of care. I used to work with old people who were said to be very dependent, but they were on their own 22 hours a day. And then they get help from neighbours, and then generalist care, specialist care, and super specialists. You see, broken bones aren't a problem. If I get run over outside here, I don't need a good GP, or I don't need the right health attitudes. I mean, I'll get scooped up and taken somewhere. But if you take painful joints, the distribution across these types of care is, well, sometimes I think a lot of healthcare is like Brownian motion. The random movement of patients, professionals, blood samples, and bits of paper. But we will need to run things in a different way. You see, we're here starting to look at the fact that the people who are receiving a specialist service are not necessarily those who benefit most from it. What's the solution to this? My own view is to think of systems and a change in the way in which doctors work. So here's the language for the 21st century. System, network, pathway. System, network, pathway. And here are the questions. I was in London speaking 2 weeks ago, and here are questions which we cannot answer still after 70 years of the NHS. Is epilepsy care better in Kent or Sussex? Don't know. We can tell you by hospital, but not by the population. Maybe completely different groups of people referred to different hospitals and different services. How many asthma services are there in London? And is that different from the number of services for inflammatory bowel disease? What's the right population size? It's sure not the same population size as clinical commission groups. So we will be getting you people involved in system design. And here's a system that a young doctor who worked with me developed for sickle cell. And this is other language for the 21st century. Objectives, criteria, standards. Objectives, criteria, standards. Now, here's the objectives for an asthma system. These are, suppose we spend £1 billion a year on asthma. We have no idea whether asthma care is better in Somerset or Devon, or whether we get the same result for £900 million. I asked a group of doctors to come up with objectives, and they've done quite well. But I'd like you to discuss with your neighbour just for 2 minutes what other objectives are there. I want you to think now you're responsible. We've suddenly got the young people's, there's been a revolution, and the old guard are swept away, and we're sent to do something useful like sweep the hospital grounds. And you people are in charge, and within London, probably you spend £120 million a year in asthma. And I'd like to think, are there other objectives that you want the clinicians to achieve with asthma? Okay, 2 minutes with your neighbour again. Go! 10 seconds to go. Right. Any suggestions for additional objectives you would like to add? Yes?
I think to make patients aware of how to, for example, use their inhalers with, so that it's effective for their care.
Right, to engage the patients fully, yes?
Yeah.
Man in the red jersey there?
To increase the effectiveness of treatment.
Yes, to increase the effectiveness of treatment, to improve things, yeah. Others? Yes, at the back?
Increase awareness, like just looking back from people in the public, how they can really help people with asthma or how to deal with it.
Okay, so that's dealing with the patient you don't see very good. Yeah, any more? Yeah?
Once an asthma system's in place, making sure that patients are educated about how this system
Yeah.
works. They know where to go and who to see, they don't know this time of day.
Let me, here ones I put in, you see, this was from discussions, and these pick up some of the points that have been raised here. To make the best use of resources, so you want to hold the clinicians to account for making the best use of resources. That might mean doing less of something, more of something else. To mitigate inequity. Where are the children being referred to specialist service? I'll bet they come from middle class areas and not poor areas. So you have to take action. You know, well, we want you to take action. Not the public health department, but you, the respiratory physician. My wife says I mustn't point too much, but I'm sure. But we want you to do it. We want you to do it. To promote research. And then this one here, to report annually to the population survey. These are examples of a systems approach. And systems are delivered by networks. We're in the network century. So in the 20th century, it's professor, consultant, GP. In the 21st century, professor, consultant, GP, pharmacist, patient. That's the network. And of course, technology starts to drive that. And if we just relax a bit and use this thing called the internet, it's there. It's just that we can't actually make the jump to do it. Your generation will do it. It will change. We will run things. Actually, he is a renal physician, and there's something called renal patient view, where all the patients have access to the information, the lab results, they are all available. And patients are given pathways that they should follow. Doesn't always work, but they're given clear information. Now here's the way I see the jobs developing. So this is now doing away with primary and secondary care. So here's Dr. Jones. She's a respiratory physician and she's terrific. Evidence-based care, patient-centered care. But Dr. Jones, how many people are there in Derbyshire with COPD? And she finds there's 1,000. And she finds there's 100 who could benefit from our specialist service. So she puts in a bid for expanding the outpatient service. But Dr. Jones, A, we've done away with outpatients as a concept, so I don't recognise your bid, and B, there is no more money. So we want you to work in a different way. We want you to be a population respiratory doctor. This isn't for everyone. You only need 1 out of 5 in the team. But I would like you, those of you who become specialists, part of your work will be thinking, as you said, of the patients we don't see. These are the sorts of things. For example, asthma. All these children coming up to A&E with asthma attacks, they don't know how to use their spacers. Who's responsible for that? Pharmacists, GPs. Who's responsible for teaching pharmacists and GPs how to teach people how to use spacer? Who runs the website? Dr. Jones. This will be new areas of work for physicians. So finally, the centre of the patient. Patient-centred care. The experience of transparency and individualisation. What do we mean by that? Well, I was involved with a young doctor setting up something called I Want Great Care, and BMA really hated this. But we said, look, patients will start slagging you off on the internet. Our system, which a number of hospitals are now taking up, you can't send two complaints from one computer. There's a whole variety of simple things you can do on the internet to stop abuse. And what we find is actually young doctors are very keen on this, because when they go for the next job interview, they can produce 30 things. Because most patients are delighted with what we're doing, but there are lots we can learn from patients. And we need to do that. We're now starting in this, in the revolution to create systems of care to work with patients' organisations, the Parkinson's Disease Society, the Multiple Sclerosis Society, and the professional groups, bringing them together. This is the way the future will go. And although these patients groups campaign and some of them take money from drug companies, they are primarily committed to the patients. And they are grown up. We can say, look, just don't campaign for more money for the next hour. Let's just talk about how we can make things better. So here's just to finish on something which I haven't managed to achieve. I don't have familial hypercholesterolemia, but let's imagine I had. Here's the way it would run. So I get reminders for a blood test on this. I can tell you, familial hypercholesterolemia, I am going to sort this out. I've got a young doc who's going to do it. We're spending hundreds of millions of pounds on statins for people at low risk, and we've only identified 15% of people with at risk with AFH. You're just not, we haven't organised a population service. So I get SMSs or messages, and my GP gets to go, why should my GP be responsible for my cholesterol? It's my responsibility, and I should be told that. And when I get the result that comes to me on my phone, so here's an example. My friends in Oxford haven't done this yet, but it says the cholesterol level is unchanged, no need to increase statins. The first step is to increase the amount of walking. Try to walk an extra 3,000 steps every day. Have you ever considered buying a dog? Here's, you see, it all says here, look, we send another blood sample and we're going to check it out. Because you only need it once a year. And if you want guidance here, we send out 600 million of these every year, and I've never seen one with proper information for patients. So of course patients go and look up Google, because we're not using it. We send 1.5 billion letters a year, and I don't know, Ian, about your own trust, but very rarely we need to put it in, because that's when people want it. Well, here, oh, by the way, so you see this one here, they find a big dog for sale. This is a lab result. You see that the lab knows my postcode, and you put in Google, buy a Labrador OX2, and that's 6 miles from my home. That's like the hairdresser, isn't it? It's, we're just not doing it, we're just not using it. Now your generation, a different generation, my daughter, who's a little bit older than you, says she's meeting young people now who don't even have email addresses. You know, they're using Facebook or something, but they don't. So we need to be working. Teenage health is a major issue that we've neglected. Here's my final picture. Here are my heroes, leafcutter ants. You see, what we've tried for the last 50 years is either bureaucracy or the market. But neither bureaucracy nor the market can tackle complex problems like how do you improve care for homeless people with HIV? How do you help people with, how do you help teenagers with inflammatory bowel disease, cope with the disease and get better? Or how do you help frail elderly people? These are complex problems. And the ants work together for the good of the colony. You don't get ants criticizing one another. You don't have this separation of primary to secondary care, or I was hearing that some hospitals even, they're getting the consultant to sign things saying they won't speak to doctors in other hospitals. The ants don't do it that way. That's why the ants are more successful than we are. So these are the heroes. There's a very good ant colony in London Zoo, and there's one in the Natural History Museum. Communicate all the time, work together, and it's the good of the colony. That's the important thing. So it's for you big challenges. I'm terrifically impressed with people coming into medicine. We need to find ways in which we can give you access to change things. We have started through something called the network. I don't know if you've been involved with the network with Nikki Kikani, making sure that instead of some of you, the pressure you see so far has been to write articles and say the Scandinavian Journal of Dermatology, that only 2 people will read, you and the peer reviewer. I mean, that's just like academics getting pressure and doing things. And that's necessary for people who are going to be academics, but the most important thing, which I think we will achieve with medical directors and the postgraduate deans, is for you to feel when you're a doctor in training that every year you've made a difference. Now, when we started these projects, some were to do with patients, but others were just improving handover at the weekend so that doctors weren't wasting 2 hours hanging about with archaic handover. That too. So we back to this issue of how do we get people like you. If you were working for Google, you'd have accountants, you'd have money to manage, people to manage. If you're working for, if you were in the army, you'd be in command of a troop of maybe 12 people, and you'd be responsible for their life and death, and you'd have to make decisions. You're in the NHS, and we don't just want you to spend your time working your socks off, taking blood, have to do that, but we need to look at ways which, I know you're a self-serving group, we engage with you. So I'm honoured by being asked. I'm afraid I've got to go to a meeting about diabetic retinopathy, but my day job on, we'd like to support this organisation, we'd like to involve you, and we need to mobilise you. Viva the revolution. Thank you very much.